Welcome everyone. In this upcoming few minutes, let me introduce you my PhD topic shortly and the progress of these last 3 months. Oops. So my name is Dóra Koch and I'm a resident from the 2nd Department of Pediatrics. One day I would like to be a pediatric hematologist and oncologist, so therefore I want to achieve the best therapeutic response with the lowest possible toxicity in children anti-cancer treatment, and we want to put the focus on the prevention of toxicity of chemotherapeutic agents. So therefore, we started 2 projects. We have gone through the literature looking for some available data in connection with pharmacokinetics and the administration routes of a frequently used chemo. And after that, we decided to create some high-quality data in connection with that topic. So this frequently used agent is called vincristine, which is a really strong base of anti-leukemic protocols and anti-cancer protocols. And we know that if these children get the information about their disease, they not only have to struggle with it, but they also have to struggle with the adverse effects and side effects of these treatment protocols. And for other drugs, we already have found information in the literature that prolonging the administration has resulted in decreased toxicity. And vincristin's most specific toxicity is neurotoxicity. So we aimed to compare the severity of adverse events in the different administration routes. So our question was that does the prolongation really cause a decrease in the severity of adverse events in connection with vincristine? So we included studies with people treated with vincristine, where the administration type was properly mentioned and where neurotoxicity was somehow evaluated. So, and we hypothesized that the continuous administration form reduces the toxicity. Unfortunately, going through more than 13,000 articles, we found just 1 comparative study in connection with the administration routes. So we included single-arm studies, and it ended in a big prevalence study. So here you can see the pooled prevalences in the different administration groups. So the continuous group and the conventional push group. It was 37% in the continuous group and 39% in the push group. In connection with severe neurotoxicity, the pooled prevalence in the continuous group was 3% and 6% in the push group. And we had a lot of subgroup analysis due to our high number of included articles, and one of them was the effect of concomitant medications, especially chemos. But here we analyzed the effect of azole concomitant therapy during vincristine administration. Here you can see the pooled prevalence, which was 6% in connection with the severe neurotoxicity. It was 6% in the push group. Here you can see that it was, when vincristine was administered concomitantly with azoles, it was 32% the incidence of severe neurotoxicity. Here you can see just the other pooled prevalences in connection with severe neurotoxicity, and this was a significant correlation. Here you can see the pooled proportions of overall neurotoxicity and investigating the effect of concomitant chemos, and we could see a tendency in connection with bortezomib. So we can conclude that we couldn't find any clear evidence still in connection with the administration routes, but there was a significant correlation in connection with the azole co-administration, and we could see a tendency in the case of bortezomib. So we still have the hope that if we modify the administration schedule or the dosing schedule, it will result in decreased toxicity. And concomitant chemo administration is a debating topic in the literature, that what is safe to use with what. And in neurotoxicity, we can say that these chemos are safe to use concomitantly. And in connection with azoles, we need a guideline revision how to administer it when we want to administer it concomitantly during therapy. And we need a patient-friendly, in the practice we need a patient-friendly method, and in the research a really precise and objective method to assess neurotoxicity, because we don't have one. And we have around 60 plots, and I'm working with the supplementary material and everything like that, so hopefully we will finalize the article soon in December. So as we have gone through the literature, and I have already mentioned, we decided to create a clinical trial in connection with this topic as well, because it's still debating after going through the literature. So only one RCT is available, comparing administration routes, and this could be a gap-filling study if we will do this. So here you can see that it will be or it is already, it is a running pilot. It will be a two-armed clinical trial in which on the one arm vincristine is administered or will be administered in a 3-hour-long infusion, and it will be compared with the conventional push injection. These are the days of the acute lymphoid leukemia protocol when vincristine is administered. And first we would like to measure, or we have some pharmacokinetic observation on these 2 days of the protocol of the induction therapy, and we would like to assess the neurological toxicity these days on the timeline. So does the 3-hour-long infusion reduce the toxicity? To answer this question, we include children with acute lymphoid leukemia and Hodgkin's in our study. We randomize them into 2 groups, so the 3-hour-long infusion and the push injection, and we will assess the vincristine-induced peripheral neuropathy. How? So we think that it will decrease the toxicity levels, hopefully. So how will we assess this? First, it was our idea to assess it with a really objective method with nerve conduction studies. But the feasibility of nerve conduction studies is quite questionable, so we decided to assess the severity and the incidence with the very well-known CTCA grading system. And if we can, we perform nerve conduction studies as well. Hopefully we can correlate the CTCA grading with some nerve conduction parameters at the end. And other secondary outcomes will be assessed as well. So we have already started our pilot, and it is running in 2 centers. We have already included 21 children, and already 160 blood samples have been collected. So here are just some baseline data about the included patients. So the mean age is about 5 years. A little more boys have attended the study, and this is the distribution of the administration now of the included patients. And I would like to show you some preliminary results in connection with the nerve conduction parameters. And we could perform it on 9 children now. These are just the baseline electrophysiologic parameters, which is before vincristine was administered. Unfortunately, the after parameters are under calculation, so this is why I couldn't show you this. But these data correlate with the data we can find in the literature about nerve conduction normal values. So just a quick summary about the projects running. We have also a third project, but I don't have enough time to share this with you, maybe next time. So thank you for your attention, and tough times never last, but tough people do. Thank you very much.
Are you collecting blood samples for pharmacokinetic observation, or do you have any other plans?
Yes, thank you for your question. in the first case, we are collecting it for describing the 2 administration routes with the exact pharmacokinetic parameters. And we had initiated a population pharmacokinetic modeling project in which we would like to show what are the parameters which is informative on this population here in Hungary and the European population. And with this program called P-metrics, we can say that what is the ideal type of vincristine administration using these calculated pharmacokinetic parameters. So yes, these are our plans, but it is a lot of work to initiate that, but hopefully it will be started soon.
My question is about the randomized control trial. And I would like to ask, was there, when you said you are investigating the neurotoxicity, on this table there's the median nerve and the peroneal nerve. Is there a special reason why you chose to investigate those, or what's the reason for that?
Thank you for your question. So we have chosen these 2 nerves because the vincristine-induced neurotoxicity mainly, clinically, it is presented with the numbness of the fingers of the hands. This is why for sensory analyzation, median nerve was chosen. And in the age group of 5, the most specific or the most common side effect is peroneal nerve paresis, and this is why we have chosen this nerve to investigate for motor parameters. So this is for sensory, this is for motoric parameters, and we examine the nerve conduction velocity and the amplitude of the evoked response. So yes, this is why we have chosen this. And also it is so we can find data in the literature about that these are the nerves in which we can see a deterioration of these parameters, especially in the amplitudes. So this was the other reason why we have chosen this.
Mainly, I think that number of patients with this test, the same test, is because of rejection of this objective test because of pain.
Yes.
So until the last time, did you find any pain-free techniques for objectively measuring neurotoxicity in children? And also, I was wondering if the ratio of older children is whether higher in this group of children. So is there a difference of accepting going through this examination between different age categories?
So your first question, which was in connection with the neurotoxicity assessment. So we have a lot of assessment methods, but we have like questionnaires with combined with neurologic
I know, just another objective
method. Yes, there are some machines we can say to use, like I can't remember the name, but it is I can't remember the exact name, but you can test the autonomic neuropathy with it, pseudo something like that. And there is another one which we have in the clinic. It's called Neurometer. It was used for diabetic neuropathy assessment, and this is what we plan to use in our third project. But you can check only the sensory neuropathy with it, and it is not so sensitive as the ENG, or the nerve conduction studies. So the highest level of evidence is what you examine with nerve conduction studies, like here, and this neurometer is like here. But it is pain-free.
But this is painful, so there is no pain-free version of
no. In the same level of sensitivity, no. Mm-hmm. Unfortunately.
Such a shame. And did you find any difference between age categories accepting to do this?
Yes, it's interesting that younger children and parents are more likely to join the study.
Really?
Yes, yes, and older
Because they don't
boys
know.
and girls who know that what pain means, they reject it because they are afraid of painful methods. And this is a really vulnerable period for them. So they reject every kind of everything, including this also. So yes, this is the tendency that younger children are more likely to join the
And
study.
what are the experiences after? So they don't really know? Sorry. Nothing.